I like saying it. Oh, and I forgot how to say it. Inflammatics. Yes, there we go. So, Dr. Tim Sweeney is an MD, PhD, and the co-founder and CEO of Inflammatics. It was actually at Stanford where he helped invent the core computational technology on which Inflammatics is based on. He's been involved with over a dozen patents related to medical diagnostics, has over 100 publications in his field, and is a PI on multiple developmental contracts with the US government. Inflammatics has come into recognition as the most disruptive technology at AAC in 2019 and made the Fierce 15 list in 2020. With that, everyone, please help me welcome Dr. Tim Sweeney, Precision Immunology Using AI.
Thank you all very much, and I appreciate the introduction. So yes, I'm Tim Sweeney. Inflammatics, a side note, portmanteau between inflammation, informatics, if you're ever trying to think about it. I understand I'm in the slot right after lunch. I apologize for not being there in person. If I was there in person, I'd be able to pick on those of you that nod off in an insulin-induced coma. But since I'm not there, you'll have to elbow the people next to you if they start to blink their eyes too much. I'm going to talk to you today about inflammatics and our journey towards bringing precision medicine to the point of care, as you can see, using a blend of transcriptomics and machine learning. Now, my personal background was in clinical medicine. I trained in general surgery, and so I was always very interested in building products that would fit into hospitals, right, where we have a lot of things that sort of come by very quickly. So Inflammatics is very specifically geared towards building the next generation of diagnostics based on areas of care where decisions are made in minutes to hours. You know, whether sort of it's a clinic where your kid is sick and you want to know whether or not they need antibiotics, or an emergency room setting, or an ICU. Inflammatics is focused on reimagining diagnostics in these acute care settings. And basically the core computational technology is mRNA signatures. Now, I'm sure all of you are familiar in general with the notion that mRNA signatures might be diagnostic. And of course, there's been a lot of application in cancer in particular. But Inflammatics spun out of my co-founder's lab at Stanford, Pravesh Khatri. And what we showed in the lab was that using a particular technique called multi-cohort analysis, we could come up with mRNA signatures, usually no more than 10 or 11 genes of interest, to separate almost trivially sort of any two diseases of interest. So the dendrogram here on the left was something we built showing that we can really differentiate pretty much anything based on mRNA profiles. But on the right was every single one of those lines, a manuscript that we published showing a best-in-class mRNA-based signature for either the diagnosis or prognosis or therapy response predictions across a large number of diseases, right? As you can see, sort of acute and chronic infectious disease, chronic disease like autoimmunity, fibrosis, organ transplant rejection, oncology. It's a really, really broad underlying technology, one that I'll get to at the end. Inflammatics in particular is focused in its initial disease vertical on infectious disease. And so I'll tell you about this first product we have, the INSEPT test, mostly today, just given the time limitation. But understand that we have a lot of products under development that all use the same basic technology, the same basic computational technology to pull together mRNA signatures of interest, whether it's in inpatient setting, outpatient setting, therapy response prediction, whatever. And we've been very fortunate to have a lot of partnership with government agencies on these tests. And my standard disclaimer, of course, is that that doesn't mean that the results are representative of the views of the US government. Now, all of our tests are eventually bound for the clinic in this device, a proprietary device we've built we call mRNA, which is a play of words on myRNA or mRNA. And mRNA, to give you a sense of scale, if you can see my screen, uses these disposable cartridges. And it's everything from a sample to answer system to quantitatively measure up to 64 mRNAs. So basically you can click a blood tube directly into this hole. We've got sort of our wet reagents for an RNA extraction in the blisters, and everything flows through then to this kind of business end where we can measure quantitatively each mRNA of interest. And the whole thing runs in 30 minutes, sample to answer. So these two together, just to give you a sense of what Inflammatics does, we really think it positions us at a unique intersection between two great and important axes in diagnostics over the last 10 years. One of which, of course, is this, this data-driven medicine, which I'm sure you'll talk a lot about at this conference, right? People that are using new insights in data science to drive novel kinds of information to physicians, whether it's in cancer mostly, but also certainly in chronic disease. But almost all these companies focus on delivering these tests through a central lab, right? You send us a sample, and a week later we've done some RNA-seq, we'll send you back the results. Well, that's great, but if you had a 7-day turnaround for a test for sepsis in the emergency department, it's perfectly worthless clinically. It's way too long. So, of course, the pandemic has shown us sort of the criticality of moving standard tests to the point of care, right? SARS-CoV-2 test in the lab is not nearly as useful as a SARS-CoV-2 test at your fingertips. But all these companies are really focused on pretty much existing test modalities. We're just rebuilding the same thing from the lab, but cheaper and near to the patient. So informatics is relatively unique in really trying to bring these two together to bring precision medicine into that point of care space. Okay, so that's the overview on the company broadly. I'm also going to start now talking about this particular application that I think will hopefully illuminate basically how the process works. And to do so, I'm going to talk to you about our first product, INSEP. And if you'll permit me, I want to tell you just a little bit about sort of what it does, what it's intended for, why it matters. And then I think you'll understand a little bit more sort of how the technology works. So the first thing to understand is, we're going after this thing called sepsis. And bear with me for a minute. Sepsis is an enormous problem. I'm a little bit on my soapbox here, but sepsis precedes half of all inpatient deaths. It is the source of 40% of all ICU dollars and is by far the single most expensive diagnosis code in all of US healthcare for CMS at over $40 billion a year. And that's all before COVID-19 hit. And severe COVID-19 is really a form of viral sepsis. So of course, all those numbers are sort of even bigger now in the pandemic. But the important thing to understand about sepsis is that it is generally not easily diagnosed. So a lot of people focus on this problem here, bloodstream infection. A lot of people think about sepsis as a bloodstream infection or quote unquote blood poisoning. But the interesting thing that you learn in clinical medicine is that bloodstream infections actually account for less than half of patients with sepsis. So sepsis is actually an immune response to a very severe infection. And it turns out that most patients with sepsis actually have a skin and soft tissue infection or belly infection or pneumonia that has never penetrated the bloodstream. So the patient's ultra sick from this immune response that's gone systemic, but the bacteria aren't actually found in the blood. And so even though we spend a lot of money looking for bacteria in the bloodstream, that's an inefficient way to diagnose patients with sepsis. And the bigger issue is, maybe there's 1 million patients a year with sepsis, and that's a very important thing. In general, if you come into the hospital looking like you might have an acute infection, or like we're pretty sure you have an acute infection, but we're not sure how sick you're going to get, you might need screening for sepsis. And in that case, we really use a lot of tests that aren't very effective. So imagine for a minute that you today went to your local emergency department with a cough and a fever. Doc, I think I might have pneumonia. Well, you're going to get a complete blood cell count, a metabolic panel, a lactate, maybe a procalcitonin, probably a chest X-ray, a nasal culture, a sputum culture, a blood culture. You're looking at something like 8 tests to try to diagnose whether or not an infection is present. And the problem with those 8 tests is not just they're expensive, it's that they don't really work that well. So this is a paper, one of my favorites, from the New England Journal. The New England Journal is 2,300 patients in exactly this situation. Showed up in the emergency department with symptoms of a pneumonia. And in this case, they have a chest X-ray that confirmed that they have a pneumonia. Okay, so 2,300 patients with a chest X-ray that shows, yep, there's pneumonia in there. And symptomatically, we know that they have one. And the question was, how often can we capture a pathogen in these patients with a known infection? And they did nasal swabs, sputum culture, blood culture, urine serologies. They do all of the kinds of tests that we have available to test for the presence of an infection. And you can see on screen, right, 62% of the time, they detected nothing, despite the fact that we know that there's an infection in there. So anyone who's practiced can tell you, I can tell you from my practice when I used to see these patients in the emergency department, you order microbiology and just sort of assume that it's going to be negative. Because infections are really hard to find. They're deep-seated. And that's really a core problem in modern medicine. So when you talk to emergency department physicians about their approach to the patient with suspected sepsis, and you say, well, what are the 3 things that would make a big difference in your ability to care for these patients? They'll tell you, I need to know whether the patient needs antibiotics, what are their diagnostics, and where are they going, right? That's what matters to an emergency department physician. They're trying to triage patients quickly, get them out, give them the help they need. And so we set out to make a test that would answer all of these needs in a single cartridge. Fundamentally, the way that our tests work is that we don't have to look for bacteria. You can see, imagine here you're a patient with this deep-seated infection deep down in the lung. Well, the infection may not penetrate the bloodstream, but the white blood cells, they come out of the bloodstream, they fight the infection, they re-enter the bloodstream. Okay, so the white blood cells are circulating in the body, sort of having been activated by this infection that they're fighting deep down in the lung. And Inflamatics's tests basically look at whole blood mRNA signatures to interpret that pattern of activation. That's what our tests do. They look at those activated white blood cells. And the test itself, basically, when you get it, you get a report like this one on the right-hand side of the screen, which is we actually, with one test, we put out 3 separate scores. And one score is there a bacterial infection anywhere in the patient? Full stop. Second score, does the patient have a viral infection anywhere? Meaning, by the way, that you could be high co-infected or low non-infected. And then a third and separate score where we can estimate how likely this patient is to move on to needing ICU level care. And you can see here on the left, these are all prospective numbers from the bacterial score. It's very sensitive and specific, it's very accurate in blinded data. So that's what we're building. So I think what you're really interested in is, how did we do it? How do we get to this kind of level of accuracy from white blood cells and what's underlying? So we like to think of generally 5 steps in test development. And of course, I'll try to lead you through these in more depth, but it all starts, of course, with measuring the right variables, right? You have to pick genes that are informative, otherwise you have a garbage in, garbage out problem. Then we're going to take those genes and develop a classifier, machine learning based classifier, to say, detect whether or not a patient has a bacterial infection. Of all of the different classifiers we train, we check performance, select the best, then we rigorously validate in external cohorts, and then we have to transfer all of that onto the cartridge, revalidate it, and then we're live. So at a high level, those are the key steps. But I want to paint for you a picture of how hard this is. In addition to all of the things that could potentially vary the immune response, age and gender and severity, sepsis in particular, really any acute condition, has these 3 issues of time that affect the immune response. So one is time since infection, right? Did you show up immediately the day you got a fever, or did you sit at home for 3 days with a fever getting worse and worse before you came in? One is time of sampling. So a lot of these studies, someone comes into the emergency department, but you don't consent them right away. Sometimes it's you wait 6 hours or 12 hours or 24 hours. And so that can affect the profile that you're seeing in the patient. And it can be markedly different after 24 hours than it was at the time they came in the emergency department. And the last is time in the hospital, right? Some patients are in the hospital from another indication and are recovering from that at the time when they get a new infection. And of course, if that's the case, then there's some background that sort of also has to be accounted for in interpreting the transcriptome that we're seeing in patients' blood. And the goal, of course, is to train something that sort of takes all of this into account across different studies, because no study encompasses all of this, right? There's no single study that's like, well, we enrolled patients at all times and sampled at all times and from all times in the hospital. Nothing can do it. Typically, they're more like this, right? Study A is sort of sampled late, and study B is sampled early, and study C is something else. But you're trying to build a classifier that no matter what, can always separate the bacterial infection from the non-infected, right? That's the goal. And to give you a sense of real world, how does this look, not just in a cartoon, the trials that we look at tend to be what we call small data. So this is not sort of a, those of you that know the Google paper, The Unreasonable Effectiveness of Data, this is not like if you just have millions and millions of patients, you can solve it. It's hard to enroll patients in the emergency department. And you're talking about, thousands of patients with thousands of markers, not millions of patients with millions of markers. And you can see here, this is a t-SNE of a bunch of cohorts that we had under study. And here the coloring is by which study they came from. And here's the coloring by which class they are. And you can see there's clearly some separability, right? I think in this case, blue, bacterial, yellow, non-infected, red, viral. But it's intermingled with sort of this issue. So our challenge is to train a classifier that, regardless of the domain, works in a new patient in a new hospital every time. That's what you need in a real deployed in vitro diagnostic, and it's quite a challenge. Now, it's a challenge that many people seek to publish papers on, but maybe haven't thought through the actual application. So one of the things that's common in the field is, well, we're gonna find the genes that work, right? We're going to go to NIH and we tell them, hey, we're going to discover a signature for separating bacterial and viral infections. And the typical way that's done is NIH says, great, so rigorous inclusion-exclusion criteria. Let's enroll just kids at just one hospital with just one inclusion criteria. And when you find the bacterial and the viral patients, the differences in the transcriptomes you see will be due to the fact that they're bacterial and viral. And you can select a gene signature that way. The problem, of course, is if you learn a full model and then you go to adults who are much more severe at a different hospital at a different time, that model falls apart. And so what's often published is people pick a set of genes and then they always cross-validate local machine learning, right? So it's like, well, like this gene set works in the kids, and then I took it over here to this cohort of adults and I retrained a model, and in cross-validation it looks good. But none of those models are externally applicable. So it sort of tells you that gene expression might be able to separate these patients, but it never leaves you with a product that could actually be applied to a patient. So at a high level, what we've striven to do instead is incorporate enough heterogeneity across the space to train a single locked model that we can independently validate in different cohorts, and that then is sort of forward applicable. Right. Once we've validated this thing works, we can take it to FDA and we can go to market. And we haven't been through FDA yet, soon enough. So basically, the way this works from a biological standpoint is, for those of you that aren't immunologists, remember that you have an innate immune system and an adaptive immune system, right? The innate immune system, macrophages, neutrophils, things that are activated very early in an infection and sort of have broad sort of killing powers. The adaptive immune system, of course, the ability to produce antibodies, but it takes several days to come online. Well, the way the innate immune system works is it has a lot of very, very highly evolutionarily conserved pattern recognition receptors. And these pattern recognition receptors, they sense broad classes of things like double-stranded RNA, which is only present in the viral kingdom, or the flagellin that's present on certain kinds of bacteria. And in response to those stimuli sort of kick off intracellular signaling patterns in the cells. And so if we pick just a few key genes inside a cell and we use pattern recognition, we can sort of back figure out, well, what was it that activated this particular cell, right? Makes sense. That's the machine learning piece. So like I said, this has two main pieces. One is the selection of genes and the other is training of a classifier. The gene selection we've published an enormous amount on. If you go to our webpage or if you look on PubMed, I mean, we've probably published 30 or 40 papers on gene selection methods. And it really comes down to this idea of you can't rely on the just one hospital with just one inclusion criteria to select the genes of interest. We always start with what we call multi-cohort analysis. So in this case, we published 3 papers, one looking at the question of, is there an infection or not? one looking at a question of, is it bacterial or viral? And one looking at a question of, can we predict mortality when a patient shows up in the emergency department? And in each one of these cases, what we did is we went to the public data, we went to GEO or Array Express, and we looked for all the public transcriptomic data we could find, and we included everything as long as it matched that basic question. And across all those data sets, which was typically about 8 to 10 studies, usually about 500-600 patients, and it was very broad, kids, adults, inpatients, outpatients, medical, surgical, whatever. We would say what genes always separate infected from non-infected. And critically, we were also one of the first, I think, to publish not just that we could find a set of genes, but then when we went to independent validation data sets, their diagnostic power was upheld. So what INSEP launched with what Inflamatics launched with 5 years ago was licenses basically to some patents based just on those initial gene sets. So where the company started was just having taken from Stanford, we know that these genes are informative because we've seen across dozens of cohorts that they're linked to our conditions of interest. But the whole problem of training a classifier, that was left to the company. So at a high level, basically, what the company does is say, well, now we know we have 29, in this case, 29 markers of interest. What we need to do is get a whole bunch of data where we can train models across those 29 genes. And of course, it has to be carefully physician phenotyped for, is there bacterial infection, is there viral infection, is it non-infected? We use some techniques in data normalization, platform transfer, some feature engineering, and then we can train a classifier, in this case, a neural network, to sort of figure out, does this patient have a bacterial infection or not? So I'll show you maybe just 3 slides sort of demonstrating, that it works and a little bit of how it works, and then we'll wrap up and I can take time for questions. In 2020, we published this paper. And this was the very first instance of this bacterial viral non-infected classifier. And the graph on the left basically showed just a little bit about how we did this. So we had, at the time, you can see a large number of data sets, each here denoted by color. Each color was a different data set. Split that into 3 groups, and even within the 3 groups, we tried different kinds of cross-validation, either leave one study out or a random folds cross-validation. And although it's a little bit small on your screen, you can see we try things like, linear models, tree-based models, SVMs, and MLPs, so some neural nets. What we showed was that in the end, we were able to train one model. It wasn't that complex, 2 or 3 layers deep, with some sort of clever feature engineering up front. And that model, critically, didn't just work in the cross-validation, but when we took that locked model and applied it in blinded samples, it remained highly diagnostic in those blinded patients. That was our first generation model. Now we're up to generation 3. And I'll just say sort of these are all studies except for this training line. These are all blinded studies showing the predictive performance of the bacterial score, the viral score, and the severity score, which are all separate classifiers. With, again, very good sensitivity, specificity, performance in these outer regions. And so I think the point is, as we've gotten more advanced, certainly the performance has gone up. And it does seem to be a method that appears to be working very well, because we are, for the first time, able now to take this blinded classifier and apply it in novel patients. Another example, just if you're interested, we just published a bunch of work that was done almost 2 years ago when COVID started, in COVID outcomes predictions. But the fascinating thing is that this model, so totally different model, I know this might be a little bit confusing, but we set out to train a model that said, can we predict mortality in patients with acute viral infections? And in that case, in these patients with acute viral infections, we actually trained from no COVID data at all, because this was like in March of 2020 when the paper was written. And you can see here on the right, sort of the left takes you through the schematic of use of multiple cohorts, how to co-normalize that data, how to train something across all of that heterogeneity. And then on the right, you can see the generalizability. So this was just a 6-gene model with just a linear algorithm this time. In the middle here, this was across showing the ability to predict outcomes in patients with acute viral infections that were not COVID, with excellent AUC, by the way, 0.94. And on the right, then there were 2 validation cohorts of COVID patients. And again, in a model that didn't even take COVID into account, with predictive performance around AUC of 0.89 in both of these, markedly similar, by the way, across 2 separate geographies. So I think the point is the basic method of, choose your genes carefully and across cohorts, train a model carefully and across cohorts, and then validate independently has now held up across a number of different application domains. And we're very excited then, of course, to be building it all into these rapid cartridges and ready for deployment in a little less than a year. Looking back, maybe just some key learnings we've had, things that we've talked about. First, when you're looking at gene signatures, really anybody building, a multi-parameter signature, cross-validation, especially random cross-validation, is not that informative. Anybody can make it look good. What you really need is an independent validation. And not independent, I mean, we never touch this 30% of our data. I mean, a fully held out cohort of entirely different patients, because that's what you're going to see in the real world. We have found that domain expertise in medicine and machine learning have to come together. You really have to have people that can understand what the data are trying to tell you, along with, along with
Dr. Sweeney, we only have 2 minutes left, so you can finish your presentation, but we won't have time for Q&A.
Oh, okay. Along with, well, we'll keep it there. So why don't we go ahead and take some Q&A? We got started a little late, so I wasn't sure if we got the extra time. So we can take maybe a couple of questions, because we did get started a little late. I was planning on finishing on time. I apologize. But if there are questions in the audience, maybe we can take a couple.
Okay, thank you. So one question that was in the chat is, what are some barriers to implementing your technology in hospitals, and how did you overcome them?
Sure. I mean, I think the number one issue with any new technology in a hospital is going to be physician skepticism, well-founded physician skepticism, right? You need a lot of data. And so we've got a little over 50 clinical studies enrolling around the world. And I think that's, so the short answer is how we overcome them is we bring the data showing that it works. And I think that's going to be the key to implementation. Of course, there's a lot of other things, right? You have to design a product that sort of fits in workflow and understand how that workflow is implemented and all the sales cycles and everything else. But I think the number one most important thing is data that shows that it works.
Thank you. And for your presentation.
Well, I'll just say, for those of you who are interested in learning more, you can find out a lot on the website.
I would like to
if you're interested in learning for an internship, we do have machine learning internships available this summer. And thanks very much for the opportunity.
Thank you very much. Okay, so now I would like to introduce our next speaker, Dr. Jake Hayward. He is an early career academic emergency physician focusing his research on the use of secondary data for point-of-care clinical decision support, data-informed policymaking, and improved quality and safety of care. He works his clinical shifts primarily at the Royal Alexandra Hospital, where mental health, addictions, and care equity are emerging topics of investigation. He completed his emergency medicine residency at the University of Alberta in 2019 and a Master's of Public Health at Johns Hopkins in 2020. Please welcome Dr. Hayward for his talk, AI in the Emergency Department, Opportunities and Challenges.
Okay, yeah, I think that works. Hello, can you guys hear me? Okay, so thank you. Thanks for having me. Thanks for the introduction. I don't quite know the audience today, so I understand we have some people online and some people in person, but for everyone in person, I was thinking, could I have a show of hands for who comes from a clinical background or who works in a clinical environment? Minority. And then is everyone else from a sort of scientific background or a computer science background? Okay, just so I know the language that I'm going to use. But I think that I can at least sort of pull from the themes of the previous talk. And I think I'll probably be touching on concepts like physician skepticism in the application of AI and ML in our world. So I'd like to give you some sort of picture of our world, and then give you some thoughts on how to guide our technologies or our innovations in injecting themselves into the world that I work in. So, it'll be pretty high level. This is not a presentation of like primary data from work that I do. It touches on themes of work that I am currently doing, but more so on the experiences I have in the emergency department and where I see opportunities to sort of help me and my colleagues. I'm going to focus on diagnostic reasoning, like the diagnostic process. So I'm going to try and describe that a little bit and how that works and where we find we need help. And sort of try and contrast how I think, I believe in self-reflection, I think about things and how I might talk to an algorithm or a data-driven support system and where that might fall apart, that communication might fall apart. So, I read this book sort of last year during my master's. I did a lot of sort of investigation on causal inference using secondary data, using methods of biostatistics and epidemiology in a more traditional sense, trying to figure out what causes what and what the effect of one thing is on another, with data that we are acquiring every day just by happenstance, just because we are now accumulating more data than we did before. And I really thought, what is the potential for us to understand the why of what we're seeing and why is this thing happening? Because that's the language I speak in. When I go to the bedside and I ask a patient what's going on, my intuition immediately kicks in. I start to think, well, why is it that you're experiencing chest pain in this way? And why are you expressing it to me in this way? And so in this book, I thought was really helpful for me in forming some initial thoughts, because I don't come from a computer science background. But Judea Pearl, who did a lot of work in causal inference and Bayesian networks and whatnot, sort of comes to this end thesis where he believes that the fundamentals of how we think as humans is different from how machines are going to think, and that strong AI is probably a long way off. And the root of that thesis is that we think in the question why. We always ask what causes what. And from the moment you're born, where you see associations in the world that are bidirectional observationally, you're asking what causes what came first, and then you cross apply those rules of the world to other situations. And that frame of thought of always thinking about the why is very adaptable. We don't get stuck in one environment. I can take the laws of medicine, the language of medicine that I learned that is sort of centuries old, and I can learn those rules and I can go work overseas and I can adapt to a new language. I can kind of adapt to a strange environment where the language is different. But fundamentally, I'm looking for the core principles. And, I think at the bedside, it's a very complex environment. And in the emergency, as Tim alluded to, it's time dependent and it's chaotic, and there's not much data. That's the fundamental definition of what I do, is differentiating the undifferentiated. So you come in, you don't have a set of data with you. You don't have an explanation with you that I can look at to explain why you're having the symptoms you have. The fastest way for me to do my job is to go and speak to you directly. I don't go to the system first. I don't go to the data first. I say, that's okay, but that's all smoke and mirrors. That's like a surface level representation. But I go to the bedside and I say, what's going on? And then I interpret you. And I have to interpret who you are and your personality and your culture and your background and how you experience pain and how you express it. And I also have to interpret your values. But all of that comes to a question of why. I say, well, why are you having this experience? And I think for us in clinical medicine, it is hard to imagine that the data that preceded that encounter is going to inform my decisions or my conversation with you, because there was not much data on you in those 2 days before you came in. There's historical data from a year or two ago, but right now, right here and now, there's not much data, and I'm accumulating, I'm getting that data. That's my sensory functions that I'm using and my interaction with you to go and seek out data that I want. So the way that you come to a diagnostic conclusion, or at least some diagnostic momentum in the emergency, would be starting with the task of establishing a pre-test probability. So I go and I speak to you and I say, what are the possibilities for what's happening? And one of those things might be a heart attack or a pulmonary embolism, but there's a limit to what I can do with my interview and my physical exam. And so I look to some more objective tests. Some tests are easy to decide on using, like, using your stethoscope could be perceived as a test, and that's cheap, it's accessible, and there's no downside. But using a CT scan is expensive, it exposes you to radiation, it takes time, and you can have other downsides like incidental findings that I don't know how to deal with and have to refer you on to someone. You get some investigations down the road and there's some downsides, right? And it's costly. So a big theme in the health system in general is to reduce costs and to stop using so many expensive tests and to just make the decision on your own. I think that what we feel is that that's a hard decision. If you're telling me that, my conversation with you is not really recorded anywhere in an objective sense, but I come to the decision that you're not having a heart attack, and that was a very reasonable decision based on what you told me, and I sent you home, but then you came back, and we know we're going to miss things. Nothing's 100%, so we're going to miss at least 2%, I would say, because that's what we think is acceptable, but you'll always make mistakes too. And so physicians are really looking for data. You're looking for some objectivity or some standard and some comparison. I want to compare myself to the population, every other doc. I want to know, would you do the same thing? And so I think that's why clinical decision rules became so popular in the last couple of years. I mean, this is the synthesis of like human and data. It's not that far off from machine learning. Basically, in the scientific world, you recruit some patients who might have the problem, and you go to a group of physicians and researchers and you say, what are all the variables, like say 20 or 30 that you think would be relevant to the diagnosis that we're wondering about, like a blood clot? And then we follow them, and then we observe who has the outcome. And then we use some multivariable analyses to determine which of the factors that we chose were the most important. And then we assign some scores to them, and then we give that to the physician. And we whittle it down to a manageable number of variables that is pretty much aligned with your working memory as a human, right? Like 5 to 7 sort of things. That's a successful clinical decision support, because I can manage that. I can remember that. I can conceptualize that. I can speak with it. I can figure out how to use it. But they're not really 100% objective. If you look at the things on this list, if you look at the second one, it's worth 3 points, and it says alternative diagnosis less likely than PE, pulmonary embolism. I mean, that's not objective. That's basically asking me, what do I think, right? That's a lot of points. And so I think I just want to emphasize that we don't really have a purely separate objective tool. I mean, really, this is a way of guiding my conversation, guiding my understanding, and giving me a bit of support and confidence. And when they do compare those decision rules in a way to what physicians naturally do, which we would call like intuition, what's my intuition or my gestalt, we actually see that the gestalt or the judgment, it performs as well or better than the rules. And that's a relatively new sort of thing, because in the history of sort of derivation validation of the rules, which is a sort of data-driven way of informing a choice, they don't compare to what the standard is, which is just the human saying, I think this is what's happening. And then when they go back and they look and say, well, what, is it actually better? Maybe it's not better all the time. And so maybe we're sort of treating ourselves in some respects. Like medicine is high stakes and I don't want to cause harm, and I need some backup. I don't want to do the CT scan. I think I already know that it is useless, but I just need a little bit of a support and a sort of like, I need some agreement with my friends or from some data. But then the conversation shifts when you come to AI, of course. And I think most experts would agree that the notion that AI will replace me as a diagnostician is sort of misguided. And it's probably not helpful, because in the clinical realm, if physicians think, well, AI and ML is this thing that's going to replace me, they immediately say, well, no way, right? You don't even have access to the same data. You're not at the bedside. You don't see what I see. You don't understand the variables. And really, yeah, as a researcher, when I look at the data that we use, administrative data or EMR data, I just think, oh my gosh, how do we even derive anything meaningful from this? Because it's not what I experience on shift. This is a very vague representation. So I think there is that question of, how do you converse with the data? How do I interact with the data? How is it going to speak to me, and how am I going to speak to it? And how am I going to know when to use the data, under what scenarios, and what the limitations are? With clinical decision rules and that sort of scoring system, we've been taught for a long time now sort of when it's supposed to be used. Not everyone knows about multivariable modeling, but they kind of understand that this is a scoring system, and it's not meant to replace you, it's just meant to help you, right? But then there's this whole notion that AI might sort of replace you. And I think part of that is because of the interpretability problem. It's hard for me to go and ask why. You know, if this is sort of what we're imagining, and this is from like a study in Yale that's going on with a pragmatic RCT, but this is sort of what would happen. You'd look at your dashboard at the top where you have your patients, and then you click on one of them, and it comes up with a risk score. And this risk score is for mortality at a year. And you know, a clinician might say, well, that's obvious. Like, I knew that. You didn't have to tell me that already. Just stop interrupting me. Or they might say, I disagree. Like, you're confusing me because I disagree with that risk estimate. Like, what am I going to do with that? I don't. But then you can't ask why. So I can't ask the AI algorithm why they came to that determination, and that's a big problem. So I think research in improving interpretability in these algorithms is really fruitful and would help with the uptake with the physicians. And there's this other problem of false alerts, the false positive rates. That's I think going to be a big problem in emergency medicine. So there's been some bad press around the EPIC sepsis prediction algorithm. That's a proprietary algorithm, which is a bit of a problem in and of itself, because you can't really get to the roots of the algorithm and understand why it's behaving the way it is. But it didn't validate well outside of the training sites in the States, and that was published in JAMA. And so I'm going to focus not on the sensitivity or like the negative predictive value. Positive predictive value means of all the alerts I get, how many of them identify the problem versus how many of them are just false alarms, right? And that's potentially a huge issue in emergency medicine, because I'm already saturated. Like if anyone interrupts me, I don't have cognitive space for that anymore. So if I get a new piece of information, that better be helpful. It better be helpful. Otherwise, you're just ruining my day. And here, like throughout an entire hospitalization, with all the hospitalization data available to you, a 12% positive predictive value is not very good. If 12% of the alerts are positive, that equates to me having to assess 8 patients to find one with sepsis. That's impossible. It's just not going to happen. And that's across a hospitalization. If you look at the timeframes that matter to me, like 4 hours, 8 hours, like my shift, I'm not seeing patients after 6 hours. I have to make decisions. If I had to assess 109 patients to find one with sepsis, I mean, what's the point? That's like a month of work or something. I don't know. So you have to limit the false positives. And it's hard, I think, in emergency medicine, because there's not much data to work with. I do think it would be helpful if these algorithms learn to say, I don't know. I mean, that's a very important thing that we do as humans. We have some introspection and reflection, and we can identify the point at which we'll make a decision, but also our confidence in the decision. And when I speak to a learner or a colleague, they might say, I believe X is going on, but I kind of want to know how confident you are. I want you to say, well, I'm not really sure, or, I'm really confident. That's a huge part of our conversation in the hospital, but I can't do that with a machine, not as of yet. These algorithms here, this one's from San Diego, at least identifies a class where they say indeterminate. We don't know if you have sepsis. I think that's a good step forward. Like, if you give me an alert, and you give me a confidence interval, that's a bit more helpful than just giving me a bunch of false positives and me slowly losing all faith in that system. Still, with their algorithm, though, the problem of specificity is still there. So, like on the left is positive predictive value, and the bottom 3 lines are from the emergency department. And like, it's still 5 to 20%, depending on the algorithm. It's not really helpful. And I do think that's because you're working with no data. So in this study, they used 1 or 2 hours of data. I wager that data was probably entered by a physician who already had their decision or had their diagnostic momentum. So I think that it's challenging to come up with something that's available from a data perspective at the door, because if it's not available at the door, I'm just going to go to the bedside and figure it out. And then I think that it's fair for me to go and interact with my system and ask the system questions. So yeah, I mean, that's the second point, is I think that with a clinical decision rule, I determine when to use it because I came up with the initial pretest probability. I think I should also be able to ask questions to my system, and they shouldn't just hammer me with alerts. That's a big problem. It does make you wonder, though, if humans and machines do fundamentally think in a different way, but they're addressing a similar problem, and they both have some legitimate approach to the problem, could we not synergize a little bit? So I can't look at 5 years worth of complex data and make sense of it. There's no way I can do that. I can go to the bedside and I can engage with my human counterpart and come to some suspicions that the computer certainly can't. And you wonder if we both make different sorts of errors and that we could complement each other. And this is an e-triage algorithm that they use in Hopkins now. And when they sort of did a behind the scenes validation and they compared what the nursing triage scores to the machine triage scores, they find that they agree a lot of the time, 80% of the time or so. But then in the 20% segment of disagreement, sometimes the machine is right and sometimes the human's right. And the directionality sort of matters. And you could kind of figure out maybe who to believe under what scenario. And you wonder, even if the nurse and the machine can't talk to each other at all, if there'd be some way to come to some democratic solution, some sort of consensus about what the actual outcome should be, what the vote is between the two. And I wonder if that's a way to go, to almost use machine learning and AI as like a mirror to reflect ourselves into and say, well, what's our decision making like? What is this alternate decision making being doing? And let's recognize we both make errors, but at least there's some comparison. This is not a visually pleasing slide, but it's another line of work that was just published out of Berkeley, where on a system level, they took patients coming into the eMERGE who may have, I think they took all patients, but let's just say you took patients who might have a heart attack, who have chest pain, and they use population, historical data to determine the risk of having a heart attack later on. And they risk stratified everyone here into like 20 bins here, into percentiles. And then they compared that sort of AI and the machine learning derived risk stratification with physician behavior. So they could show that the machine could, predict when patients would get more tests done. And then the higher risk patients would have a higher proportion of positive results from their test. And that's informative. I mean, it's kind of a comparison of the machine learning pre-test estimation with physician behavior, which is a reflection of my own pre-test likelihood estimate. Even if I don't record it, my behavior suggests that I thought there would be a heart attack because I tested for it. Now, the question with this sort of line of work is probably how do we adjust and understand our own behaviors and improve the value of our testing? But the flip side of the coin is if you don't test someone inappropriately, they could go on to have a misdiagnosis, a delayed presentation, and they could suffer harm because the heart attack was missed. I mean, that's what drives me to order a lot of tests, right? So the ML in this case was able to predict in a way who would come back with a misdiagnosis. So the patients who have a higher likelihood of a heart attack before that testing period, they were more likely, if they weren't tested, to come back with a missed heart attack. We could say missed. It was not necessarily missed, but potentially missed. So that also gives you the capacity to understand how you might encourage physicians in general to alter behavior. The current sort of party line in quality improvement across the system in testing is to reduce testing. Stop ordering so many CT scans, they're expensive. What this sort of precision risk estimation can allow us to do at a population level is to determine if that's true across the board. Because if you lower your testing rate across the entire population, you'll miss more heart attacks. If you look at from a health economic standpoint, that has a life cost associated with it and an economic cost. So the current efforts to reduce testing in general may not be actually very prudent when you look at the overall effects. And this graph, the blue, the green, the yellow suggest different levels of adding tests to the high-risk patient, to the low-risk patients. Adding tests to the high-risk patients, removing tests from the low-risk patients, or keeping testing as it is across different cost effectiveness thresholds, which is something that your system would sort of set for you in a value-based way. But the fundamental point is that ML can help us understand ourselves a bit more in terms of the patterns of behavior that we have in our diagnostic decision making, because it's a bit of a mirror as a different way of thinking, a different estimate. And I'll switch gears because I have like 2 minutes, but I will say that sort of problem of having someone show up at the doorstep with no data, there's nothing there. I don't understand the context. Maybe they can't communicate with me. And I have to make decisions with no data under conditions of uncertainty in a time pressured scenario. I really do want to know what happened in the last couple of days. And so we are trying to push a little bit. We're trying to push forward in terms of utilizing wearable sensors and the sort of smart watches and wearable devices that people have on them all the time, because they're starting to develop a pretty impressive capacity to measure a full complement of vital signs like temperature, heart rate, your respiratory rate, oxygen saturation, and blood pressure even. And this has really been pushed forward in the time of COVID, because we send patients home not knowing what the disease is going to do and if they're going to come back. And we really want to know if they're developing a hypoxia at home. And so, yeah, we're trying to push this forward to develop digital biomarkers of disease and to use that data that people have so that I can at least understand a little bit about how you ended up in my emergency department, and then use that data to inform my decisions. And ultimately, hopefully you could use that data to have some preventative interventions to prevent your emergency department visit in the first place. But there is some emerging data to suggest that you can develop some biomarkers of acute disease from these continuously monitoring devices. It's not perfect data, right? It's not all medically validated that your smartwatch data is as good as the vital sign monitor in the hospital. But that said, it's longitudinal, it's continuous, it's a lot of data, and it's personal, right? It's within yourself. So you have a norm, even if the discrete estimate is a bit off from what the truth is about your temperature. You can imagine that if you're trending towards something higher, it might be the delta that matters. And I think the concept of having continuously monitored people in an ambulatory care setting is very different from what we currently do, which is the only way to monitor you is to put you in the hospital. But these people in Stanford are doing some interesting work with wearable data, and they published some of their algorithms around COVID, because they were able to find within heart rate and activity data, comparing the two and using some ML, they could figure that there's changes in your resting heart rate that precede your symptom experience and precede your diagnosis of COVID, and then actually predict the severity of COVID. So, that's all great. I don't think it's going to change people's lives right now, even though they are pushing out an app for it. But I think that the same concept of developing a biomarker for a disease, for all sorts of disease processes, would be great. And if I could get that data, or if people could get that data in an open source or democratic sense, so that you can access that and it could help you, I think that would be a great way forward. So overall, in a larger sense, I think in conclusion, I don't think you can remove the human from my job. I would, in a way, I'm not opposed to that. I think of all the hype around AI replacing physicians, I think I'll probably be the last to go. Radiology, dermatology, things where it's visual recognition is probably a bit easier. I don't know, my job is so messy. But I think ML and AI can teach me about myself. I think it can help, it can be a tool. And I think we'll recover some insights from large data sources that we otherwise wouldn't. That's it, thanks.
So thank you, Dr. Hayward. Thank you, Dr. Hayward, for your talk. You taught us a lot about how emergency medicine can use AI and such challenges that come with it. So now we will have 5 minutes for questions. And as before, if you have any, please step up to the mic in the center, and online attendees can use the chat function. Thank you.
Thank you for the great presentation. I was wondering, at the first slides you mentioned about causality. I was wondering if there is any increase of using causality and causation, and was it helpful, like any form of explainability and causality to help you in those critical moments of when you want to make a good decision?
Are you thinking sort of the machine learning AI applications in a causal inference world?
Yeah, was there any kind of efforts in that direction?
I'm not an expert in it. At the time when I was reading that literature, I did try and look into what's being done to see if AI or ML can inform or push forward the science of causal inference. I kind of haven't looked at it in a while. I know that there are efforts underway. I was a bit sort of lost in the philosophy of it, the fundamental question of like, I think that's why I ended up with the book that I did. I was like, is this actually possible? They're fundamentally different things. But there is work that is geared towards improving our causal inference using tools that are derived from ML. I think that would be really hopeful, and I wish I could look into it more, but my work hasn't really gone in that direction. But I think if the ML world, the AI world could help us ask that question why and give us better answers to that when using big data, that I think that has a lot of potential. And if that made it to the bedside, that's great. That would be fantastic. Kind of like the ML driven clinical decision rule that is better than the ones of old. Yeah.
Hi, Doctor. First of all, thank you for the insightful presentation.
Whereas,
I was just wondering, do you have an experience of how you had to converse with data you've given and whether it helped you through your patient's condition? And if so, like, how do you figure out which data was important from the data that's given to you?
yeah, that's a good question. So in those sort of clinical decision rules that I told you, I assume you're not really speaking of those per se. That's like, that's sort of, it's not precise and individual in terms of like the EMR feeding me some data about my individual patient. It's more like applying epidemiology in general to a disease state. That's how we normally apply population level data. We take those clinical decision rules, which have made the population-based epidemiology studies a bit more digestible, and then we use them at the bedside. I personally, like in our EMR implementation in Alberta, we haven't bought the AI algorithms from Epic, like that sepsis algorithm and whatnot. We don't use that. I don't have firsthand experience with that. We do have built-in best practice advisories and alerts that pop up. And you can imagine that is taking individual patient data. It's not a complex modeling process, but it will tell you this patient is at risk for whatever. Like a good example is I often now have an alert that says this patient could be pregnant and needs some like pregnancy screening, but it's totally useless. That it's not the question I was asking with this patient, And so we just ignore it. We just shut away all those advisories. And I think the challenge of precision medicine and EMRs and clinical decision support is to find a way to make that advisory useful. If you can tell me something that's useful, that's great, but you generally don't know what I'm asking because you're not talking to me. You don't know the question I have. And so I think that interaction is really important.
Thank you.
Yeah.
Thank you so much for the insightful presentation, Doctor. I was just wondering, what is the outlook of the medical community towards all this recent development? Do people see this with fear of losing their jobs, or is it something that people look forward to?
That's a really good question. And there's a lot of that sort of surveying and landscaping going on right now. I've seen a whole bunch of research surveys come across my desk that are asking physicians what their perceptions are, where they think the utility is going to be. And then I can't tell you, I can't give you a data-based answer to that. I would say in my field, we're certainly not worried about being replaced. We're just looking for something that's actually shown to be useful. It just sounds like a lot of hype. And to anyone who doesn't work in research, I think people are very skeptical. I think there's even skepticism about those clinical decision rules, which we all use and are taught about. When it comes to AI, I think there's just too much, not really translatable rhetoric out there for understanding what it even means. So you need some case examples. So 1 or 2 successful tools to really just intuitively convince people that it works. Now, I can't speak to radiology. I can't speak to the sort of visual diagnosis and recognition type disciplines, because those are the ones that typically are identified as being a bit closer to having a somewhat suitable replacement algorithm. I still think that in those fields, the threat of being replaced, I think, is not a very tangible threat. It just hasn't made it to the doorstep yet. But I don't have a full understanding of the state of science in those disciplines, so I don't want to speak to them.
Just one follow-up. Do you think the application of AI might be more towards the diagnosis side, like maybe like you said, clinical, rather than things that involve surgery and anesthesiology and things like that?
To be honest, my prediction is that diagnosis will be one of the last things. it's my sense, clinical diagnosis to me, it's like the art and science of medicine. It's all dependent on this human interaction between physician and patient. Things that are a little bit more procedural, algorithmic, visual, if someone's interpreting a slide or interpreting an image, and there's a little bit of a containment to the variables at play that can determine the outcomes. And then when you speak about the controlled setting of an operating room with a patient who's actually asleep, to be honest, you're dealing with physiology, continuous monitoring, mechanical tasks, tactile tasks. I think that those are more accessible. The chaos of trying to operate with 10, 15 conversations all at once with different people, that's a hard thing to do. It's a lot of mess, to be honest. Yeah.
Thank you very much, Dr. Hayward, for that presentation. Let's get a quick round of applause, everybody.
Thanks.